Welcome to the Memorizing Pharmacology podcast. I'm Tony Guerra, pharmacist and author of the Memorizing Pharmacology book series, bringing you mnemonics, cases, and advice for succeeding in pharmacology. Sign up for the email list at memorizingpharm.com to get your free suffixes cheat sheet, or find our mobile-friendly, self-paced online pharmacology review course at residency.teachable.com/p/mobile. Let's get started with the show. All right, welcome to OTC Allergy, Cough and Cold. We'll go over antihistamines, decongestants, nasal inhalers, expectorants, cough suppressants, and analgesics. But it's an amazingly small number of medications with all of these different lists. So let's start with antihistamines, and we need to talk about the antihistamine snowman first to make sure we know what antihistamine we're talking about. So we're talking about H1 antihistamines versus H2 antihistamines. So an H1 antihistamine, and this snowman has one nose, are allergy antihistamines like diphenhydramine, which is Benadryl, or loratadine, which is Claritin. So when we say antihistamine, we're thinking H1, but technically an H2 antihistamine, and that's why we have two buttons at the stomach, are H2 blockers. So they are also antihistamines, but we don't call them that. And so famotidine, which is Pepcid, and now Zantac's brand name has taken famotidine, which has always been Pepcid. Cimetidine and Tagamet, nizatidine and Axid for acid reduction. So just to be clear, the antihistamines we're talking about are the ones in the nose in this particular video. So let's talk about the first versus second generation. The first generation is diphenhydramine or Benadryl, and if you've ever gotten Tylenol PM, that's the PM part of it. So Tylenol PM is actually two different drugs. Chlorpheniramine or chlortrimeton is one that we don't use a ton anymore. It only lasted about 4 hours, but used to be in packages when you had some kind of really bad allergic issue. They make you super sleepy. So really not a good thing, especially if you've got someone driving or somebody does driving for a living. So the second generation came along, and what you'll notice is that each one of these has a pair. So the second generation non-drowsy antihistamines were loratadine, and then when that went off patent, all of a sudden desloratadine showed up, which is Clarinex, so Claritin to Clarinex. When cetirezine's patent went away, levocetirizine comes along, which is Xyzal, the owl, if you've seen the commercials. And then terfenadine was removed from the market because of cardiac issues, but fexofenadine, which is the safe metabolite, is Allegra. So those are our five, second generation antihistamines that we use. And so let's take a look at Benadryl or diphenhydramine, and it's, again, we're going to use the I-match mnemonic, so indication, mechanism, adverse, contraindications, and what a healthcare professional should do to make it so that's easier to take. So allergy and insomnia, that's the indication. The mechanism, well, it's an H1 antihistamine, so it's first generation though, so it's also going to have anticholinergic effects. That's going to be important for adverse effects. So as we've kind of gone into really a lot of depth, anticholinergic was our bud cat, so the drowsiness, dry mouth, confusion, and there's a paradoxical effect where in young children, a lot of times it'll actually make them hyper instead of tired. So confusion is a little bit of an addition to the mnemonic I've used before. So angle closure glaucoma, that's one of the contraindications. And then on the Beers list, so we want to avoid it in the elderly because of that drowsiness and confusion, and we don't want to have falls and things like that. So a couple mnemonics, some people call it Benadryl because you're so tired. And then no diphenhydramine. So no driving hydramine reminds you not to drive on this one. Claritin and Alavert, levocetirizine, which is Xyzal, fexofenadine, which is Allegra. These tend to be the popular ones now, the ones that have kind of taken hold. So in terms of indication, it's all the same thing. It's all an allergy. They're all H1 blockers. They're all second generation, not sedating. And they really, in terms of adverse effects and contraindications, we really don't have a ton there. But you really do want to tell them to prophylax before allergy season, not wait until allergy season and say, okay, well, take your antihistamines. If you know allergy season is coming, go ahead and get on that regimen right away. So loratadine has the atidine ending. Be careful, that's a little bit close to tidine, which is the H2 blockers, those famotidine and so forth. Levocetirizine, or even cetirizine, if you take that TIR, make it a tear to remind you that it's allergy eyes. It's the saddest owl I could ever find. And then Allegra, if you put the R here, it makes ALLERG, change the A to a Y, and you have allergy. Somebody got paid $1 million to figure that out. I want to be that guy. All right, let's go to the next one. Alpha-1 agonist and vasoconstriction. Like, what's going on? I thought we were just doing OTC stuff. Well, an alpha-1 agonist, you'll probably know, pseudoephedrine, which is Sudafed. Oxymetazoline, or oxymetazoline, sometimes I hear, is Afrin, and then phenylephrine, which is neosynephrine. The big difference is pseudoephedrine is something you take every day, or you can take daily. It's a tablet, whereas oxymetazoline and phenylephrine are both inhaled, or nasal inhalers, and that's going to make a really big difference when it comes to some side effects in terms of those. And I always use the pop mnemonic, so just like your ears pop on the plane, nasal congestion, just think of a big pop once that nasal congestion goes away. So pseudoephedrine starts with a P, oxymetazoline with an O, phenylephrine with a P. Going on to pseudoephedrine, so let's start with what it's for, sinus congestion, and it can be used as an adjunct in allergic rhinitis. It does have that alpha-1 vasoconstriction, but the problem is it's systemic versus that nasal, which is a little bit more local. So we're going to get that anxiety and insomnia, just kind of a restlessness that comes along with it. So the contraindications, and I've got this little hand holding a heart. So it's angina, coronary artery disease, closed angle glaucoma, hypertension. All these things are really things you don't want to have if you're going to be taking pseudoephedrine. And the way that I think about all the adverse effects, I just think of energy drinks. If you have one too many energy drinks, anxiety, insomnia, restlessness, that's pseudoephedrine, and then the next ones we'll see in a second. So watch out for any other stimulants that might interact with Sudafed. Okay. Oops. Next one here is oxymetazoline, which is Afrin, and phenylephrine, neosynephrine. We're going to see it's the exact same thing as Sudafed, or pseudoephedrine, with the I, the M, the A, except we have something called rebound congestion. So around 3 to 5 days, you might get rhinitis medicamentosa. Rhinitis medicamentosa is where, and I've got this picture here of somebody who has congestion. The word breathe, because now they can breathe. They've taken their medication, the phenylephrine and oxymetazoline, and now they've got it again. So the rebound congestion, that's something that is really inherent to these nasal inhalers, contrasting the Sudafed or the pseudoephedrine tablets. Fluticasone, mometasone, we see that sone ending, so common with many of the steroids. These are nasal versions of it. So with those oral versions, we're always washing our mouth out to make sure that we don't get candidiasis, we don't get dysphonia, which is that hoarseness or difficulty speaking. So looking at the names, the brand names kind of give it away, Flonase and Nasonex. But they're both for allergic rhinitis. They're both anti-inflammatory steroids. The adverse effect tends to be a dry nose and nosebleeds. Infections like TB and varicella are something that we really want to avoid, reducing the immune response. And then you really want to use this daily as soon as that allergy season starts. So it takes about 3 to 4 days to see that optimal effect, and we do want to watch growth rate because it is a steroid after all. So I've got a guy here looking at his clock like, I don't understand. When I took the oxymetazoline, the Afrin, my nose was cleared in a couple minutes. Well, it's going to take a couple days with these guys. All right, dextromethorphan. So this is the D and M. So the dextro makes the D, the methorphan makes the M in Robitussin DM or Mucinex DM. They both have the same ingredients. The dextromethorphan part, okay, and we'll get to the guaifenesin in a minute, that's the cough suppressant for a non-productive cough, okay? It works in the medullary cough center, and it can get that CNS toxicity, dizziness. There's something called robocopping that if you use it illicitly. Hepatitis is a contraindication. And really, what you want to try to do is stop that cough from happening in the first place, and a cool humidifier can sometimes do that. You might call it, instead of dextromethorphan, you might call it dry cough methorphan, because that's really what you want. Is if that's a dry cough, it's not really producing anything, dextromethorphan is your man. Okay, guaifenesin. So this is Robitussin or Mucinex with or without the DM. So without the DM, it is just guaifenesin. With the DM, it's guaifenesin and dextromethorphan. So I want to make clear this is an expectorant. We'll talk about a mucolytic in a minute. So this is an expectorant for mucus secretion. It loosens and thins the phlegm, makes it easier to expectorate. Adverse effects are just less common, same with contraindications, and really it's just if you had that cough for a week, well, maybe you should see a physician or a provider. And I've just got a picture of kind of some slime here, an exit for expectorant, and heard it sometimes called green phlegmicin instead of guaifenesin, just kind of an easier way to remember what this thing does. Okay, acetylcysteine. Now this is a mucolytic. Now this is not over the counter, but what I wanted to do was contrast it, because sometimes you'll see that they say guaifenesin is a mucolytic. It's an expectorant. So acetylcysteine, though the actual utility in cystic fibrosis is somewhat unclear. Cystic fibrosis, acetaminophen overdose, those are two uses we would have for acetylcysteine, or mucomist. It is a mucolytic, and it loosens those bronchial secretions if you inhale it. And then it replenishes the glutathione in the liver from the acetaminophen metabolite. So if you're doing those kinds of chemistry in your particular pharmacology class, that's really how it protects it against an acetaminophen overdose. Nausea and vomiting are adverse effect, as well as, you just want to be careful with asthma, maybe a GI bleed or something like that. And then there's a poor taste when it's inhaled. So the way to remember acetylcysteine is for cystic fibrosis, as we have this cyst in cystic fibrosis. And then when you look at acetyl, you take the acetyl group and you think about N-acetyl para-aminophenol. Well, what is N-acetyl para-aminophenol? Well, that is acetaminophen. Okay, so that's the whole chemical name, or APAP if you've had it abbreviated before. Okay, so this is just a bigger picture of it if you want to see kind of how the cystic fibrosis compares to a healthy lung. All right, ibuprofen. So Advil and Motrin, and then the naproxen is the Aleve. Pain, fever, and inflammation. This is important because we're going to contrast it with acetaminophen in a minute. Mechanism, it's a non-steroidal anti-inflammatory drug, an NSAID. So non-steroidal is just a way of saying it's not prednisone, but it's an anti-inflammatory. It's cyclooxygenase inhibitor, and we're not going to get into the weeds with that right now. If you want to talk about Celebrex and Celecoxib, you can kind of get into the weeds when you start putting in prescription drugs. But GI distress, ulceration, certainly adverse effects, especially if used on long term. If you have any kind of an allergy to aspirin, or stomach ulcer, heart failure, liver disease, this really tends to hold on to fluid, and those are conditions where you really don't want to hold on to fluid. And then always mentioning take it with food, it does tend to upset the stomach. So one contrast is, well, when do I take ibuprofen? When do I take naproxen? Well, ibuprofen you have to generally take like 4 times a day, where naproxen maybe 2 times a day or 3 times a day. So that tends to be it. And then I had a pretty decent graphic about peptic ulcers, and then here is a larger version if you wanted to look at that. Just kind of explaining what's going on. We didn't talk about Helicobacter pylori, which is really the causative factor in many ulcers, but that's getting into prescriptions and triple and quad therapy, which we will not. All right, last one here is going to be acetaminophen or Tylenol. You'll notice that in the indications it has pain and fever, just like ibuprofen, but the inflammation is missing. So that's the one question you get over and over again. It's a non-narcotic analgesic, and it's just really liver damage, liver conditions. That's really one place we really want to be careful. And then watch for overdose with RX meds. And what I mean by that is maybe somebody's on something called Vicodin, and there is acetaminophen in it, and then they're taking Tylenol over the counter, or they're maybe taking some combination cold product that has acetaminophen in it. Really, you don't want to go over 3,000 milligrams in a day. The upper end is 4,000, but you really want to be careful there. So N-acetyl-para-aminophenol, that's how we made Acetaminophen, or APAP. And then here are the stages of liver damage, and I just wanted to have it up here so that if that's something you wanted to kind of go through, you could. And then a larger version of the same graphic. Okay. All right, again, this is for informational purposes only. It is not medical advice. If you have a medical condition, consult a medical professional. Thanks for listening to the Memorizing Pharmacology podcast. You can find episodes, cheat sheets, and more at memorizingpharm.com. Again, you can sign up for the email list at memorizingpharm.com to get your free suffixes cheat sheet, or find our mobile-friendly, self-paced online pharmacology review course at residency.teachable.com/p/mobile. Thanks again for listening.